Okay, so we have starting the webinar maybe in a couple of minutes. Attendees are coming in. Okay, that's nice. For now, we have about 15 attendees. Some of them were with us also in the session of on 17 August. Some of them are new, I believe, which is a good mix. More people are coming. Let's wait maybe another minute, and then we can start with my short introduction and with the webinar. Okay, so let's start. Let's start. Good morning, good afternoon, good evening, everybody, and welcome to this webinar on sanitation and hygiene throughout and beyond the COVID-19 pandemic, co-hosted by the Sanitation Learning Hub, which is part of the Institute of Development Studies and UNICEF. My name is Gian Melloni. I am a research officer at the Sanitation Learning Hub, and I facilitate today's webinar with the support of my colleague Teixeira Briggs-Graham, also from the Institute of Development Studies. Teixeira, would you mind sharing my slides?
Yeah.
Okay, thank you very much. Can you please jump to slide number 2 if you don't mind? Thank you. In the meantime, so the Sanitation Learning Hub is a research and learning program that provides practical support to sanitation and hygiene practitioners, policymakers, and decision makers, and produces current thinking about inclusive sanitation and sanitation research methods. We also create space for sector sharing and learning within the sanitation and hygiene space, which is what we are doing in today's session. Next slide, please. This webinar series is about sanitation and hygiene throughout and beyond the COVID-19 pandemic. We are trying to find answers to an overarching question about how to keep working towards long-term sanitation and hygiene objectives during the pandemic. We are not looking very much at the short-term responses, but we're trying to look at successes, setbacks, adaptations, and what this means in terms of sanitation and hygiene programming now and in a post-pandemic future. The first webinar took place 2 weeks ago, and it focused on governments and utilities. Today's webinar is about sanitation, hygiene, and the new normal. Next slide, please. Before we start talking about, next slide, please. Before we start talking about today's webinar, let's do a little bit of housekeeping. So you will see in your screen, there is a Q&A button that you can use to type your questions to speakers and panelists. And I will do my best to facilitate this kind of conversation. There is also a chat box that some of you have already started using, and you can use the chat box to let us know about you, who you are, and what you do, if you wish to do so. Also, as I mentioned already, there will be 2 polls during this webinar. so please stay tuned. And at the end of the session, there will be a survey that will pop up in your web browser that you are very welcome to fill. Now, let's talk about today's webinar. Next slide, please. Today, we are going to talk about sanitation, hygiene, and the new normal. And we have some great speakers. We have Jacky Nee from the London School of Hygiene and Tropical Medicine in the UK. We have Carlota Muyanga from UNICEF in Mozambique with her colleague Delphine Nasavele, also from UNICEF in Mozambique. Then from One Drop Guatemala, we have Raquel Porras and Ermenek Duran. And finally, from PSI India, we have Sanjay Singh and Dinesh Kumar. So speakers and panelists from very different geographical areas and very different operating contexts. I think this is it. Just let me remind you that the first part of the webinar is going to be about the presentations. And you are very welcome to type your questions in the Q&A box while the presentations are ongoing. The answers to those questions are not going to be given just after each presentation, but they're going to be given in the second part of the webinar. So we make sure that the questions and answers are fully integrated in the debate that will follow. And please don't be shy, ask all the questions that you would like to ask. Now, I think this was enough for an introduction. So if Jacky, you are ready, and if the presentation is ready, if the slides are ready, the floor is yours.
Great. Thank you very much, Jean. Right, perfect. So as Jean mentioned, my name is Jacky Nee, and I'm an assistant professor at the London School of Hygiene and Tropical Medicine. I'm also part of the technical expert team at the COVID-19 Hygiene Hub. And for those of you who might be unfamiliar with the Hygiene Hub, it's a free online resource that provides technical information on COVID-19 as it relates to WASH, as well as case studies of COVID-19 WASH programming from around the world. If you haven't checked it out, it's worth a peruse. And today I'm going to be giving you sort of a brief overview of one of the technical resources that's particularly relevant to all of you and to the webinar today. And that's unpacking whether it's possible and probable that SARS-CoV-2, the virus that causes COVID-19, is transmitted via feces. Next slide, please. So this slide gives you just a bit of a roadmap as to what I'm going to briefly cover in the next 6 or 7 minutes. We're going to try to answer the question as to whether SARS-CoV-2 is transmitted via feces. So in order for SARS-CoV-2 to be transmitted via feces, it must be infectious upon release from the body. And this is a really important point and the one that I hope you come away from my presentation remembering. You've probably heard quite a bit about RNA, or the genetic material of SARS-CoV-2, being detected in feces and wastewater. RNA itself is not infectious and does not pose a risk of transmission. Further, RNA can be detected from quote unquote either living or dead virus, and its detection does not indicate the presence of a live infectious virus in feces. The reason you end up hearing so much about it, though, in sort of the scientific literature base is because its detection is much, much easier than, say, detection of live infectious virus. Hypothetically, there are 2 main pathways that SARS-CoV-2 could be transmitted via feces, and that's sort of the classical fecal-oral route that you hear about for other enteric pathogens, as well as the fecal respiratory or fecal aerosol route. And I'm going to give you a quick summary of each of those on the next slide. And finally, there are several other factors. Oh, sorry, can you go back? Yeah, thank you. And finally, there are several other factors in addition to the requirement that infectious virus be shed in stool that can influence sort of the likelihood of transmission via feces. And that includes shedding patterns in feces, the environmental persistence of the virus, the infectious dose, and the influence of mitigation strategies or infection prevention and control strategies for the virus. I'm going to quickly talk through each of these factors, except for infectious dose. The reason being that we don't currently know what the infectious dose for SARS-CoV-2 is. And that infectious dose in this context sort of just means the amount or the concentration of virus you need to be exposed to in order to become infected. It's also a bit outside the scope of this presentation. Next slide, please. Thank you. So this slide gives you a bit of, so fecal oral transmission refers to the process whereby disease is transmitted via the feces of an infected person to the mouth of a susceptible individual. The transmission can occur through failures in sanitation systems, leading to exposure via various routes, including food, water, hands, flies, inanimate objects, or surfaces. And this route of transmission is classically depicted via the F diagram, which you see on the left side of the slide. Because COVID-19 is largely considered a respiratory disease, another potential route of transmission is the fecal respiratory or fecal aerosol route. This would occur when feces from an infected person becomes aerosolized via some process like toilet flushing or the mechanized emptying of an on-site sanitation system. And then those aerosols containing infectious particles are inhaled or otherwise deposit into the respiratory system. Next slide, please. So I'd now like to briefly touch on each of those sort of influential factors that influence the likelihood of transmission of SARS-CoV-2 or in fact any fecal pathogen. So the first is shedding patterns or characteristics. And what I mean by that is essentially understanding when, for how long, and what amounts do humans shed the SARS-CoV-2 virus or parts of it, like RNA. So shedding of SARS-CoV-2 is fairly common among COVID-19 patients. A recent meta-analysis found that about 50% of patients had detectable SARS-CoV-2 RNA in their feces. And while there's tons of evidence of sort of RNA being detected in stool, there's very limited and mixed evidence of infectious transmissible virus being detected in feces. So if you remember, RNA is not infectious by itself. To date, there have only been sort of a limited number of studies that have detected infectious virus in the stool of just a handful of COVID-19 patients. And part of the reason for that might be that it's much more labor intensive and difficult to actually detect infectious virus in stool. And part of it might be that we might not actually shed infectious virus in large amounts in our feces. So as you can imagine, both the duration of shedding and the quantity of virus shed would be important factors when thinking about the likelihood of transmission. Duration can vary widely among patients, but it seems to last for an average of about 17 days, which is quite a long time when you think about it. The amount of virus or RNA shed also varies by person and over the course of the infection. So high concentrations have been observed in stool, and this is potentially because the virus is able to infect and actively replicate in the cells that line our gastrointestinal tract. And in fact, that infection in the GI tract is probably the reason why we see many COVID-19 patients presenting with GI symptoms like diarrhea. Next slide, please. So another important factor that influences the likelihood of transmission via feces is the environmental persistence of the virus. And that essentially means how long the virus can stick around in an infectious form once it leaves the body. So human viruses like SARS-CoV-2 don't replicate in the environment. So once they leave the body, their concentration is going to start to decrease. And as you can see, the amount of time the virus sticks around in the environment depends highly on the environment it's in. So for example, in water and wastewater environments, we know that it sticks around for up to 2 days, but you do see a very large decrease over those 2 days. So risk in those sort of matrices is going to be dependent on the starting concentration in the water or the wastewater. It's also important to note that much of what we know about environmental persistence is based on laboratory studies in very controlled conditions that aren't necessarily generalizable to all water or wastewater environments, for example. It's also important to note that viral RNA is much more persistent in the environment than infectious virus. So if you go off and start perusing sort of the environmental persistence literature yourself, keep in mind that studies that measure RNA instead of infectious virus are not accurately reflecting actual exposure risk. Next slide, please. And then the final factor that can influence transmission via feces is the effectiveness of any sanitation and wash mitigation strategies. So broadly, the types of safe sanitation systems that are described in the WHO Guidelines on Sanitation and Health should reduce the risk of exposure to all fecal pathogens, including SARS-CoV-2. Further, conventional wastewater treatments are effective in removing or deactivating viruses like SARS-CoV-2. Because there is also potential for fecal aerosol transmission, precautions should be taken to reduce splashing or the release of aerosols while working near human waste or using sanitation facilities. This can include very simple steps like closing the lid of a toilet before flushing, but also more complicated steps like ensuring that all plumbing and ventilation systems, especially in multi-story, multi-family housing units, are properly functioning. Next slide, please. So now we're going to come back to that initial question we tried to answer about whether SARS-CoV-2 is transmitted via feces. While we see that shedding patterns and environmental persistence patterns hint that transmission is possible, particularly in places where sanitation is lacking, there's very limited epidemiological evidence to date that SARS-CoV-2 has been transmitted via feces, and that includes via sort of animal model studies. Though this could obviously change as more studies look at this potential source of transmission. It's therefore generally accepted that the risk of transmission due to exposure to feces is likely low, especially compared to primary transmission routes that involve contact with respiratory secretions. However, that risk is not zero, and safe sanitation systems remain important to prevent transmission of all enteric pathogens, including the SARS-CoV-2 virus. Next slide, please. And those are just the references if you're interested to go back and see where any of this information came from. And I think we're holding questions to the end. So that is it for me.
Thank you. Thank you so much, Jacky, for this presentation. I think it was very informative, and yeah, it's important to keep in mind that when we make decisions as sanitation and development practitioners, it's important that those decisions are based on evidence. And I think this kind of information goes in that kind of direction. Now I see that questions are starting to be typed in the Q&A box, which is great. If there are any very specific answers, speakers are welcome to answer those questions directly in the Q&A box. If this doesn't become too disruptive to the webinar speaker. Now, I wonder if Carlota is ready from UNICEF in Mozambique to speak to us about the impact of the COVID-19 pandemic on CLTS programming.
Yes, of course.
Please, the floor is yours.
Thank you. Thank you to Sheila, and thank you to everyone. Good morning or good afternoon. My name is Carlota Miaga, as already said. I'm working for UNICEF Mozambique as a WASH official, and here with my colleague Delphine, who is working in a sub-office in Sofala. So we are going to share our experience on how to continue with the sanitation, the promotion of sanitation and hygiene during the pandemic. Next, please. Hello, next, please. Thank you. So, before I would like to say that Mozambique is the previous slide, please. I would like to say that Mozambique has adopted the CLTS as the main approach for the to accelerate the sanitation results, and also to have ODF communities. So this was adopted as a main approach for sanitation and hygiene promotion. And those activities were or are implemented by private consultants, which can be companies, and also by NGOs that are working in a social area in Mozambique. Those entities normally have a contact with the government to work in a certain geographical area in the country. And normally triggering are done in communities and schools, depending on if the community has a school inserted within the community or not. So when we had the outbreak of the pandemic, the first measure that was adopted even by all sanitation stakeholders and also by government was to stop the meetings and gathering of people and so on. So because of that, the triggering activities were stopped for a while. And this was also to comply with the measures in terms of avoiding the transmission of COVID, such as the social distancing, the prohibition of meetings, and so on. Next, please. Next slide, please. So with time, we start to think that maybe we will live for a while with the pandemic, and we start thinking on how to continue with the sanitation and hygiene promotion. And we started, after several months of stopping activities, we started to discuss on how to do this. And the first thing we decided is that we should have a reduced package for this triggering. Thinking especially on reducing the time and respecting the social distancing, respecting the use of masks and hand washing and so on. Because we thought that, for example, promoting the hand washing was also one of the measures to prevent the COVID. And also we realized that we need to continue having results on sanitation, or we need to continue having ODF communities. Next, please. And these discussions was made involving all sanitation stakeholders. I'm talking about UNICEF and other organizations like NGOs like World Vision, Helvetas, and also government entities at national and provincial level. So we came up with a specific tolerant CLTS package that initially were piloted in 3 provinces that have direct support from UNICEF, and later on this was scaled up to other provinces in the country. So this package was essentially to allow the social distancing between within people that are attending the triggering. And for that, we also had to respect the maximum of people allowed to be in a meeting, which was at that time was 50. This number can vary according to the situation in the country and also in the province. So for that, we decided to invite a specific group of people to participate in the triggering, not inviting all community as was done previously. And we also thought that we should reduce the time of the session, and also in the triggering include the COVID prevention messages. Next, please. So to have all that reduction in terms of timing, in terms of people and so on, we also decided that we should only select the very important tools to be used during the triggering. We all know that for triggering, we have several tools that are used to complete the process. So we decided that we also should pick only the most important tools. We have the singings, the dancings, and so on. So we skipped that because we think that that can be also a moment of contact within people, and it's not good for the COVID transmission. And we maintain the community mapping, but we changed several things in terms of touching the material, the sand or ash or all those materials that are using to to mark the map. We kept the poop calculation. Yes, we continue with hand washing demonstration, and we reinforce it even the hand washing demonstration, as we now have the hand washing station, the tip tap at the meeting place. People when arrive for the meeting, they wash their hands, and during the triggering, we also explain how to construct the tip tap and how to properly wash the hands. We maintain the transmission route, and we also do the demonstration of construction of latrine and tip tap. And the work plan that previously was written and designed by community now is just discussed, not working in paper to avoid people being together and using the same pens and paper. As I said, we reinforce the hand washing demonstration. And we also think that it's very important to reinforce the monitoring after triggering. As it's not all community that appears for the triggering, it's important that after that, the community leaders and all influent people that participate in the triggering spread the message within the community, and also we reinforce the monitoring. Next, please. So with this process, we learned that all approach should be seen as something dynamic. We cannot have approach and we think that we will do it at the same way every day. So in this case, we had to look at the CLTS as something dynamic to allow it to be adjusted to the current situation. And we also learned that it was very important to have the consultant with the field staff, because those are the people who are in the field and they know the dynamic of the communities and they know how things can be changed and have results at the community. And we also learned that the tools should be adapted for a specific situation, not only COVID, but other situations. And it's also important to review the training materials or training package so that we can have the same view and the same way of doing things when there's a change. Next, please. So looking at the main change that we did, we skipped the dancings during the introduction when we go for the triggering, and we skipped the transit walk by all community. Only a group of few people from the community does the transit walk, and when back they explain what they found there. And we also skipped the food testing. We know that during the transmission route, we used to have the food and water testing. So we kept this part. And what is new here is the hand washing demonstration with the tip tap at the meeting point, because now we have the hand washing there. And we also reduced the time of the triggering. And I think we think that those new ways of doing the triggering can be maintained even after the new normal, or those can be for long-term change, because we know that at the community level, for example, people are busy with other activity as farming or other things. So if we can always maintain the triggering shorter, it will be good. Next, please. So when we started this tailored packet of triggering for COVID, as I said, this was piloted in 3 provinces, which is Sofala, Tete, and Manica. And the thing is working in Sofala, which is one of the provinces where this was piloted. And after the triggering using this specific package or the reduced package, we had a CLTS community evaluation this year, I think was in May, and we had some good results. Now I will hand over to my colleague Delphine to explain the next two slides, which show which results we had with this reduced package. Delphine, I hand over to you.
Thank you, Carlota.
Excuse me, we are a bit short in time, so can you please do this in 30 seconds?
Yes. Yeah. These two slides is to show the result when using this. This slide shows the results. If you see on the left, this family is one of the sample during certification community. And if you see, this is a guy that is part of the team that is certificate community. They create the gate to ensure that all people that go visit family have to wash their hands before enter it. Yeah, this is a experience that the family is resilient for COVID-19, and during COVID, we saw that there have changed about some issue, but they create. We had two tip tap for hand washing in the toilet and beside the ditch. But now they have this tip tap that they call it tip tap COVID-19. Yeah. Tip tap is a hand washing facility. Yeah. Next slide, please. Yeah, this slide is to show that people saw that they lose a lot of water, little water in the rural area, and they have a family with creativity, and they decide to use the part of water that they use to irrigate the vegetable garden. That is to show that was what is happening in Sofala. Thank you.
Okay, thank you so much to Carlota and Delphine from UNICEF Mozambique. Now let's take a minute for the first poll as a break in between presentations. So Teixeira, would you mind sharing with our attendees the first poll, launching the first poll? Great. So you see the poll is made up of 4 questions. The first one is asking where you're based. The second one is asking in which organization you are. The third question asks about your gender. And the fourth question asks whether you attended our webinar that took place 2 weeks ago. Please feel free to answer freely because all answers are anonymous. We are keeping this on for a few seconds. This also helps our speakers to get ready. The next speaker will be Raquel from One Drop in Guatemala. Let's wait until some more answers are coming in to our first poll. Some data are still coming in. Let me see. Okay, so let's look at this. If we look at the geographical areas, we can see that we have three winners. The first region is Central Asia and Southern Asia, followed by Sub-Saharan Africa, or maybe at the same level as Sub-Saharan Africa, and followed by Europe and Northern America, with smaller representations for Northern Africa and Latin America. And in terms of organizations, there is a pretty good spread of participants among national, local NGOs, international NGOs, United Stations, and academia, education research. But also the other categories are represented. We have a slight prevalence of male participants versus female, 59 versus 35%. And about half of the participants in these sessions took part in our webinar on the 17th of August, while the other half did not. So yeah, that's interesting to have this kind of mix. So Teixeira, would you mind ending this poll and sharing the results with the audience? Okay. So I think now we can proceed with the next presentation, which is by One Drop in Guatemala. This is a presentation that was recorded in advance, but Raquel and Ernenek from One Drop are with us, so they will be taking part in the Q&A and the debate. So now we can launch the presentation, and Delphine, would you mind muting yourself? Thank you.
So,
I cannot hear the audio from Raquel. Can I please invite all speakers and panelists to mute their microphones? And Teixeira, would you mind trying again with the pre-recorded presentation?
Good afternoon, everyone. Thank you to the Sanitation Learning Hub for inviting us to this webinar. El Lazos de Agua program is a multi-stakeholders partnership that seeks to provide sustainable access to safe water, sanitation, and hygiene to around 200,000 people in Colombia, Guatemala, Mexico, Nicaragua, and Paraguay by 2022. In Guatemala's Quiché region, the project intervened in 4 municipalities, where 80 to 90% of people are part of the indigenous Quiché group. This project, which closed in December 2020, provided over 40,000 people with sustainable access to wash and more than 81,000 people with social art for behavior change interventions. Whatever people worked in this region for several years through their Everyone Forever model. In 2018, this project was added into the Lazos de Agua program, wherever people integrated One Drop's ABC for sustainability model in order to support systemic behavioral changes for sanitation and hygiene impact in these communities. As part of the Everyone Forever model, they have been working closely with communities and governments, wash service providers, and microfinance institutions from the very beginning of the Quiché program. This model combines triggering events through a community-led total sanitation approach, CLTS, with One Drop social art for behavior change approach, which is a long-term strategy to inspire, activate, and sustain change. This model implementation was done through a value change approach, allowing the development of market-based solutions to strengthen the value chain of wash-related products and service. A series of workshops given by community-based organizations supported in giving capacity building trainings for self-built wash units. The strategy included offering solutions that enable families to take actions and resolve their wash needs through the provision of credit or through their own means. For hygiene-related goals, the strategy was to support self-built wash units by ensuring a range of mechanisms. Households were supported to build their own toilets with financial instruments, capacity building, and credit-based solutions. The principal challenge encountered is that all in-person activities related to the demand generation through community organization had to come to a halt due to the pandemic. Restrictions were imposed by the government and then were further reinforced by the indigenous communities to bar entry to outsiders. This included municipality personnel and personnel from the implementing partner. There was therefore no in-person access by anyone who was not part of the community. The pandemic also caused an important reduction of the projected activities related to self-building of wash units. People just were not accessing the appropriate credit or materials in order to be able to continue with them. This also resulted in a reduction in demand for toilet constructions credit due to the changing income stream from livelihoods. Group gatherings were not permitted, which changed the way programming is usually implemented. This was also slated to be the last year of the project. Due to the outcomes not being met due to the pandemic restrictions, there was ongoing talks with funders, governments, and the implementing partner to ensure that program outcomes could be continued through a response plan. Despite this, the project had its achievements. Among other results, open defecation ended in the Queca community, a municipality of Santa Cruz del Quiché, and total water and sanitation coverage was attained in public institutions in the municipality of San Antonio Elotenango. The program wasn't designed to provide emergency response. As an initial part of the project, we had undertaken a retrospective exercise identifying the strengths of each project. This resulted in strengthening relationships with key mapped actors that had been developed for many years, even before the start of the Lazos de Agua program. The implementing partner maintained constant communications with distinct actors such as the municipality, governments, education and health, community committees of development, water committees, and other community leaders to maintain the communication channels active. Through this, we were able to continue to support the communities that could not be accessed by personnel to continue in attaining the goals of the project. The principal factor for success is that we were able to reestablish contact with communities due to the ecosystem of actors that had been previously strengthened as part of the project and through the IP's ongoing long-term presence in these communities. The adaptation was to privilege the communication through telephone, and to avoid the potential and that the intervention change from being able to welcome a whole team to only allowing a person. This required the collaboration of all actors with the IP managing this coordination. However, most people in the communities did not have access to phones, and so that trusted existing relationship between the municipal actors and community leaders was key. We've learned that we depend so highly on working closely with people on the ground and within communities. The importance of creating a network of actors and to strengthen local system, not only the implementing partner to communicate, but really to build collaboration and trust between actors is crucial. This means governments and then at the municipal, state, and national level, water utility committees, community development organizations, microfinance institutions, and water user committees. Innovation in the management structure that allowed flexibility. Whenever possible, work with the implementing partner and actors who have a strong understanding of the system and the actors who are present. Work with people who have been there for a long period of time, and understand the context. The team of Water for People speak the local indigenous language, Quiche, which made communications easier with the population, and through them, we were able to build collaboration with trust. This affected and helped to support our understanding of the community's challenges and their vision of water. This helped to better understand the barriers and drivers of sanitation behaviors in the communities and to design a systemic program for sustainable impact. Innovation and adaptation were also possible due to the close integration of OneDrop's ABC for Sustainability and Water for People's Everyone Forever models. When we go into an intervention, it is important for users to be at the center of their own changes. And this requires a lot of planning in order to center all the activities and services based on the needs of the users, people. Despite the changing priorities for vulnerable households due to the reductions in livelihoods due to the pandemic, a small portion of them still elected to continue the auto constructions of their toilets as they saw the benefits to their health. Thank you to the Sanitation Learning Hub for giving us the opportunity to share our experiences. If you want to learn more, please visit us at lazosdeagua.org.
Thank you. Thank you so much to Raquel and to OneDrop for this interesting presentation from Guatemala. And now let's move to a very different geographical context, very different continent. We are moving to India. And if everybody, everything is ready, let's leave the floor for PSI India for their 10-minute presentation, please.
So, thank you, Anne. So, hello, everyone. So in next 8 to 9 minutes, I will be talking about one of the intervention that PSI made in one of the provinces in India, in Andhra Pradesh, where we worked on behavior change communication for improving behavior towards toilet use. I will talk about what were the disruptions during the COVID and how we tried to overcome from that and what has been the learning. Next. So just to give you a context or background for this, the project area for us was around 400 villages in Chittoor district of Andhra Pradesh. So there were around 240,000 households in this project area, and the toilet coverage was quite good. It was around 75%, while the usage was quite low, and only 23% of the households were using toilet. Apart from this 23%, there were households where the toilets were in use, but not all the family members of the household were using toilet. So in this background, we started our project, and next slide. To understand what is the trigger and barrier and what is the baseline and all those things, we conducted formative research and baseline. This also helped us to develop our communication model. We tested 3 concepts in the project geography, and we came up with our communication model, and our communication intervention was heavily dependent on mid-media campaign and interpersonal communication. Next. So in mid-media campaign, it was basically a kind of mobile van that was equipped with multiple community engagement activities. There were many messages. So the whole idea was to create a budge in the villages so that the follow-up activities can happen. And while the interpersonal communication activity was focused more on identify the toilet defaulters who are not using the toilet, because they were our target audience, and it is very difficult to find among thousands of people who is using or who is not using. And apart from this, the interpersonal communicators were required to conduct sessions at household level, sessions at the workplace, and also some special events for the targeted men population, because they were the main defaulters in that project area. Next. But with all those preparations, we worked in that geography for around 1.5 years. And this COVID thing came. And as I mentioned, our whole intervention was heavily dependent on mid-media and interpersonal communication. So because of lockdown and all those things, all these activities completely halted. And even post-lockdown period also, there was a limited mobility because people were not allowed. There were many restrictions and all those things. So our one-to-one group activity or one-to-one, meetings, even after lockdown, when it was relaxed, it was not very much welcomed in the project geography. Staff was also infected because, it was very highly, infectious time when this project was being implemented. So our resources also got reduced. Then government officials were really helpful because from the beginning of the project, we were taking their support to implement the project through them. But because of the COVID priority, they were all engaged into those things. And we had a vast capacity building program for implementing that in the entire district of Chittoor, of around 15 to 1600 villages where 15,000 people were to be trained. That also got disrupted. So with these disruptions, we also tried to come up what to do that, how to do, and we also didn't want to lose the momentum that we had created during 1.5 years while implementing this project. Next slide, please. So these are the few adaptations that we made. It is very simple, but that helped us a lot to remain in touch or continue our program and get the results. So this our interpersonal communication that was mainly face-to-face meeting or group meeting or community meeting, that was replaced with telephonic counseling. For this telephonic counseling, we created a script for our interpersonal communication, where we also included COVID messages because it was the requirement of the time, and it was also helping us to create or build a relationship with the community with whom we worked in the past. And we also trained these our staff in communicating with the community through teleconversation, because teleconversation requires a different set of skills. Everybody is not ready to do these kind of jobs. So to bring them on board, to train them, we created a large, kind of training modules, and that was delivered through virtual team meetings or trainings. We also created a system where these contacts or the quality of contacts can be validated. So this validation system was also through the telephone itself. So these were the things that we did. Apart from this, parallelly, we also developed some video messages, and knowing the fact that at least 50 to 60% of the population where we were working, they had a smartphone, we also utilized this medium so that parallelly telecommunication and this video messaging can, help our, intervention to continue. Next. And post lockdown also, it was not easy to continue working because there were special permissions we took from the government for our staff to continue working in the area. We also brought in monthly COVID allowances for the project staff, and that was more for masks, face shield, sanitizers, hand gloves, and all those things that are required. So we brought in from to our staff from the project itself, and because of the limitation, this group meeting, community meeting was reduced to only 2 to 3 people with whom the staff started meeting after the lockdown. This whole, 50,000 volunteers training also had limitation because we were not supposed to conduct those trainings in a hall or the meeting room. So we decided to conduct these trainings in open in a group of not more than 4 to 5 people. Next. So I would say the couple of things became new normal when we started working. So that the large community meetings, which was the core of the whole implementation, and the mid-media campaign was completely discontinued. Social distancing and masks became new normal. Telephonic counseling in the subsequent program we also included, not only in this program, based on the success of the implementation during this first phase of the COVID, where we contacted around 65,000 households or individuals through the messages that we had designed. Same was applied in the next program or subsequent program in the same geography where we are working or we have completed. Apart from this, because virtual trainings and virtual meetings, they are very efficient, economical. So that is why they became integral part, and we are continuing with this. Next, please. The major learning that we got from this particular intervention was that how the telecounseling or the teleconversation can become integral part of the whole behavior change communication. The point which I want to highlight here is that telecommunication cannot work standalone. It requires, activities in the field, then it can be clubbed. So the point is that if the field activities or the interpersonal communication or physical meetings can be intelligently clubbed with the telecommunication, that will be the best thing that can be done, because this will, be efficient. This would reduce the resources required for a whole lot of communication activities that will be required with the physical presence. But at the same time, telecommunication or conversation requires a lot of preparation and a lot of training. So whoever is going to be involved, first thing that it could be integrated in all the behavior change kind of programs that are required. Second is that all the staff, whether there is COVID or not COVID, they have to be trained on the teleconversation thing, because it's a bit difficult and different from the physical meetings or trainings that are required. Of course, last but not the least is the virtual contacts have saved a lot of time and resources for us. So I will stop here. Thank you very much for your patient hearing. I will be here for your questions.
Thank you. Thank you, Sanjay, for this interesting presentation about about the work of PSI in India and the use of telecounseling and telecommunication-based solutions. It is now the time to move to the last part of the webinar, the part about the debate, as all our presentations have been completed. There are a number of questions that have been typed in the Q&A box, and some of those questions were very specific for very specific speakers. For instance, there was a question about the design of toilet lids in Mozambique, and those questions were already answered by the speakers in the Q&A box. So let's see what questions were out there for all speakers, and let's try to start this this conversation all together. Please feel free to keep typing questions in the Q&A box, and I will do my best to consolidate questions and to dispatch them to the speakers and panelists. So I think there was a very interesting question. I think initially for One Drop, which I would like to ask to UNICEF, One Drop, and PSI. The question is about adaptations. So this adaptation in sanitation programming that we have been describing, who designed those adaptations? And I think it's a very relevant question because it's important to flesh out whether here there are kind of top-down or bottom-up processes ongoing, and also to discuss whether this is an opportunity for local communities to have stronger voice or not so much, and it depends really on the context. So this is the question that I would like to ask to the three organizations who presented these adaptations. Who designed those adaptations? Who tested those adaptations? Who validated those adaptations in sanitation and hygiene programming? Maybe we can start with One Drop. And please try to keep the answers a bit concise and to the point, so we have the time to interact more with the attendees. Please.
Thank you, Jan, and happy to be here. I'm gonna take this question on behalf of One Drop. So basically, as the approach of social art for behavior change is based on collaboration and co-creation with communities, the adaptations had to come from this in the same way. So adaptations were made with the executing partner that it's on the field, who at the same time had conversation with community members. As Raquel explained in her presentation, community was very difficult because even in addition to the restrictions of the national government of Guatemala, there were some restrictions imposed by the communities that didn't want outsiders to come into their communities. So this increased the restrictions. But one point that Raquel made in her presentation is that good communication was key. So they had established previously communication channels with community members. So this allowed them to continue the conversation even during COVID time. So short response, it's a bottom-up approach. It's a participatory approach, and it's a co-creative approach that was created because that is in the ADN of the SABC approach of One Drop and ABC model.
Thank you so much. Thank you so much, Erminek. So UNICEF in Mozambique, who would like? Maybe Carlota, would you want to take this one? Please, Carlota.
Okay. The question is who were involved in the discussion. In Mozambique, sorry, now I can take out my mask, sorry for this. In Mozambique, the discussion involved, I can say, all stakeholders that are working in sanitation and hygiene implementation. We are talking about UNICEF and all international and national NGOs that are working on sanitation, and specifically the government entities at provincial and national level. When we talk about NGOs, we involved people at, how can I say, at management level, but also the community workers. And in this case, the information that we receive from community workers were very important, as they were the ones it was very important for us to hear from them what is possible to do at the community level and what is not possible to do. And our main question was not to jeopardize the results in terms of sanitation, but also not to go above the measures that were defined to avoid the transmission of COVID. I don't know if Delphine would like to add something.
No, Carlota, it's okay.
Thank you.
Okay, that's great. And so now PSI from India, who would like to take this question about the top-down or bottom-up or two-way approach in designing the adaptations?
Okay, Jan, thank you. So, answer to your question is that we thought how we want to continue in the given situation and what are the things that we can expect to do in the given limited or restricted, environment. And one thing that the whole team agreed that we do not want to lose the already built momentum that we have. If there is a gap of 2-3 months, probably we will have to work harder to, re-establish our relationship. So that is how this idea came, that the first thing is to crack how to continue our engagement. So that is how this adaptation model was designed. The second is that how it was verified. So while designing the whole model, we also kept a place for the verification of this whole model. And also, it's not that at the end of the whole intervention, this will be, tested or evaluated. It was evaluated almost every 3 days or 4 days time to provide or give feedback to the people who were really part of this whole teleconversation system. So this was very much part of the whole adaptation designing, and how it was designed and why it was designed, I explained already. Thank you.
Thank you. Thank you, Sanjay, for this. There are more questions that I'm trying to that are trying to merge from the Q&A box. Another question that I may ask, and I think it is a question that is relevant to the three speakers, but I think I want to ask this specifically to Carlota from Mozambique, because you work on eliminating open defecation in rural settings. So the question is, what about slippage? Have you observed an increase in the rate of slippage with the communities you work with?
Thank you. This is a very important question. And for me, as a person who works with sanitation and working with CLTS, for me, slippage is always a big challenge. Specifically in Mozambique, the recent example I can give is that, for example, in Sofala province, where Delphine is working, is the province that were affected by Idai in 2019, then by Eloise last year. Before Idai, we had a lot of UDF communities, and the same districts were flooded. So when floods comes, all UDF communities are slippery. So we work again in 2020. I remember in 2020 we had the triggering monitoring. We had more than 160 community that were candidates to the evaluation. We did the evaluation in November and December. Then in January, the Eloise cyclone came again. So we had all those communities slivering even before the evaluation. So even in those places where there's no such events as floods and so on, we always have a big challenge with the sliverage because of different cases as natural cases. And thinking on this COVID situation, we don't have that at the moment, but I believe that yes, COVID might be influencing the number or increasing the number of slippage communities. As we know, with this COVID situation, the economic situation, the stress at the community level and family level is increasing. And unfortunately, for majority of communities or for majority of families, a priority. So if the family is under stress, and if they have to put their effort or money in something else, they won't choose sanitation as the priority, but they will choose something else. Thank you.
Thank you so much. I think these are very, very sensible and very real kind of considerations about not only our point of view as sanitation practitioners, but also the point of view and the priorities of people who live in communities and who are struggling with livelihoods and with so many issues around it. Thank you very much for this. I would like to ask a question now to PSI, so Dinesh or Sanjay, about you mentioned because you have worked a lot in telecounseling activities, and this is a question that came up in the Q&A box, but it's also a question that is quite close to my kind of thinking. You know, sometimes we think of remote work and digital technology as something that break barriers in terms of access. But when we talk about relatively isolated rural communities with limited access to technology, my question is, how do you see this as something that breaks barrier, or is it something that creates new barriers? It's a big question. Okay. I'm aware of that. It is just to hear your thoughts about it, even if you don't have a firm answer.
Okay, so you're right. I don't have the firm answer, but I would start from saying that when we adopted this model, we knew that this is not a complete solution. But knowing the fact that this is not a complete solution, at the same time, this is a very effective solution if it is combined with something else. So we know that fortunately, the area where we were working, we had around 60% telephonic access, smartphone access, and almost 75 to 80% household had access, maybe simple phone or the smartphone. So if there is no phone, probably this model cannot be implemented. But in terms of barriers are definitely there, because our idea was that we will be talking to those people only who are the real defaulters of the toilet use. While it's not necessary while implementing that all those individuals who are really defaulters do have phone. So in that case, one has to very intelligently, combine the person who is having phone and who is not using toilet, how to contact and how to, send your messages or the conversation to that particular person. So there is no complete solution that if one does not have phone, how to contact. There are many ways through which the message can be communicated to that person. And those methods are all, local kind of solution. It's not a big problem that we noticed while implementing our project. Jan, you are on mute.
You're on mute, Jan.
Thank you. Thank you. I know this was bound to happen sooner or later. I was just thanking Sajid to say that it is important to keep in mind that when we're talking about remote solutions and technology solutions, this is not the full picture. This is just something that can be part of a more complex and multifaceted kind of approach. Now, I have a quick question for Jacky, because this is something that emerged also in a couple of questions in the Q&A box. I don't know if Jacky, are you with us? I hope so.
Yeah, I'm here.
Oh, great. So the question is, you've been talking about the links between sanitation and transmission of COVID-19. So the big question is whether there is a link or not, or the link that exists, is it something that happens in practice? Is it something we should be worried about? Is it something that we should keep in mind when we design sanitation programs?
Right. So I feel like I'm going to give you quite a diplomatic answer on this, but it's because we have found infectious virus in feces, it's possible that this virus is transmitted via contact with fecal matter. Where the big debate is whether or not it's likely that it's transmitted. And those are sort of the points that I went over. For it to be likely for it to be transmitted, that depends on the amount of infectious virus shed, which we don't know. We only kind of know about the amount of RNA, which is not infectious, amount of RNA shed, how long it's going to stick around in the environment, and how often humans interact with that environment. The infectious dose, which we don't know, that's how much virus it takes for you to get sick once you've come in contact with it. And then sort of the effect of mitigation strategies. So by all accounts, it's possible, but it seems to be not very probable that it's transmitted via contact with fecal matter. That doesn't mean that the literature base couldn't change on this as people keep doing more studies and keep learning about sort of transmission via this pathway. But currently it's sort of those primary transmission pathways that are the main ways that this virus is making its way through communities. That doesn't mean that it shouldn't be a priority and that there's not a link to sanitation, because there potentially could be. And there are also just so many other pathogens that we should worry about that are transmitted via the fecal oral route. So certainly sort of prioritizing sanitation and hand hygiene as it could potentially relate to COVID-19 is still important. And I think there was a question as to whether there was any evidence of actual transmission occurring. There's sort of been some circumstantial evidence coming out of China, I believe, that there was a case of fecal aerosols being spread by sort of a faulty plumbing and ventilation system in a multi-story housing unit. And that's sort of what I mentioned as an example in my presentation. And that's also something that has happened previously with the SARS outbreak that happened back in 2003. There was evidence of that happening too. So maybe not necessarily the traditional fecal oral route, but we are potentially seeing it being transmitted via this fecal aerosol route, which is sort of a new way for us all to be concerned about disease transmission. So possible, but maybe low risk is the short answer.
Okay, thank you, Jacky, for this diplomatic answer, as you put it down. I think that's a good approach, because if we have some points on which we are not certain, I think it is important to be able to state that there are uncertainties, rather than trying to identify a nail and start hammering on it. So yeah, I think this is very helpful to the conversation.
Yeah, I would use the precautionary principle here.
I think it makes total sense, and I think it is also good learning for us as people who work in sanitation. Now, I would like to ask. There are more questions in the Q&A box, but let me for a second ask a slightly different questions to all the organizations who have been presenting about their own experience today. Imagine in a post-pandemic future. Imagine in a future where the current pandemic is more or less over or under control. What is an aspect of sanitation and hygiene programming that you will remove from your programs because it's outdated? And a new aspect that you have developed during the pandemic that you will keep as a long-lasting innovation. So this is, of course, something that cannot be said for sure, but it's just to try and kind of go through this exercise together. So maybe, yeah, let's have one drop starting with this. Something that you would drop from your old programming and something that you would add based on what you have learned during the pandemic. Very, very, very concisely, of course. I don't know if Ernenek or Raquel, you would like just to start on this.
Thank you, Gian. I will try to give a concise answer to your great question. Probably I would drop off the traditional mode to develop or give assistance to these communities. And I strongly maintain the combining in the interventions that combines different approach like social art for behavior change and CLTS, as we have seen or we are seeing important results achieved by communities.
Thank you. Thank you so much. This was real concise, and yeah, and definitely interesting. PSI, Sanjay or Dinesh, something that you will drop and something that you will add.
So yeah, I think I would say that it's not that what are the things that will be dropped or what are the very new things that will come into it. I think the more important is that how to rebalance considering the fact or the based on the past experiences. So for us, for example, we learned that how digital medium can work better. So in our programming, probably we will more focus on how digital medium can play more, important role rather than the actual, heavy lifting at the field level. Because combining these two probably will be helpful, all those people who have access to digital medium and all those people who does not have. So leaving any part will not serve the purpose. So probably I would say it requires rebalancing rather than leaving anything.
Thank you so much. Carlota or Delphine, same question.
I don't know if Delphine would like to answer this in terms of what we would like to keep and what we would like to draw. Delphine, can you?
Yeah, it's very difficult because all of that we do, it's very important for the community. But if the situation continues, yeah, I think we need to create capacity in local area to reduce movements of people come to the like provincial level to the district to do promotion of sanitation and create a link about a different area, health, wash, to ensure that we have these different area work together. We work together now, but I think we can increase our coordination. I think that is good to ensure that we avoid, we reduce our presence in the community level. Yeah, that I.
Thank you so much. Thank you so much, Delphine. I see that everybody is trying to think in terms of what to keep or what to improve or strengthen. We are all a bit cautious when it comes to dropping program components. Now, very quickly, I'm aware that Jacky is not a sanitation implementer. She is rather from the academic world, but she is very familiar with sanitation and also with the issues that we deal with in sanitation. So from your perspective, which is maybe a bit more far removed, Jacky, what do you think is an aspect of like the classic way of sanitation programming that may become less important in future? And if there is any new aspect that will become more prominent in future?
Yeah, I mean, that's a great question. I think sort of what the COVID-19 pandemic has highlighted to all of us, including those of us in academia, is sort of how far behind all of our WASH systems are. Because sort of imagine the scenario, I'm talking about the probability of this virus being transmitted via the fecal oral route is low. Imagine if it hadn't been. Imagine if this virus had been transmitted via feces in sort of the same risk levels as it's transmitted via aerosols or droplets. We'd kind of be looking back and being like, wow, we were really underprepared. And we know this for sort of endemic diseases that are huge issues, but sort of a global worldwide pandemic that was fecally orally transmitted or fecally aerosol transmitted. I think this pandemic has really highlighted how underprepared we are for that. And I think sort of what we're going to move towards, and this is, from sort of academic discussions, is sort of these professionally managed sanitation systems where we're not just doing piecemeal one-off interventions in communities and then sort of leaving them to their own devices after we've implemented that, but sort of a move towards professional universal delivery of WASH systems, not just sort of one-off WASH interventions. And I sort of think that's where, in light of the COVID-19 pandemic and sort of the limited progress towards SDG 6 that we're seeing, I think that's really been the motivation for sort of a rethink of what is the WASH agenda going forward, at least for academia, and hopefully also something that a lot of NGOs and civil servants and governments have begun to think about too. So I think overall it's been a good motivation to sort of rethink how we need to switch the WASH agenda to support sort of resilient systems that reach everyone and are professionally delivered and managed, not just initially implemented and then left.
Yeah, and can I build a little bit on what all the participants had said?
Yeah, sure. Please take
45 seconds
maximum. I would like also to
45 seconds.
Yeah.
I would like to build on what Raquel said about leaving like traditional approaches behind, and this links with what Jacqueline is mentioning and what Delphine is mentioning. I think we should start thinking on how we really strengthen like local systems, because we see how difficult it is to go back to communities once like pandemics like this hit. And to this we need to bring innovation, like not only like technological innovation, but thinking innovation, managing systems innovation. We need to think in working closer with the private sector. They will be there anyway. So we need to start building these other like innovative partnerships to be able to answer to the needs that we are already seeing and where we know we are really far behind. So I would like to just mention that at that point. Thank you.
Thank you. Thank you, Menek. I think this is a very interesting and important, looks like a paradox. You need to strengthen systems, and this looks like a professionalization, as Jacky said, but also the theme of localization and local solutions has been emerging more and more because capacity needs to be local if there are limitations, for instance, in movement or in communications. and this is an issue for everybody. All right, I think we are reaching the very end of our time here. Let me. I'm not trying to draw any conclusions from this, because it will be very hard, and probably in 1 year, 2 years, 5 years from now, we will be all much better placed to try and think, of the impact of COVID-19 in our way of doing sanitation and of thinking sanitation and hygiene. For now, what we can do, we can try and look at the things that are happening around us and try to make sense out of that. I think some recurring themes in the questions and also in all the debates and presentations is, I would say, the unknowns. So we need to be honest about the fact that there are so many things that we are in the process of learning. And so there are unknowns out there, and we need to be able to recognize those unknowns. And likewise, there is no silver bullets. We have heard from many speakers and panelists about integrated approaches, combined approaches, rather than something that will be the solution to all issues. Also, maybe we can be quite confidently saying that some form of remote work, of remote outreach is here to stay. Use of telecommunication and remote technologies to some extent. And keeping in mind, as Sanjay said, that this is a rebalance. So we are not ditching old ways of working with communities, but we are trying to add and integrate new components to it. And also, it's important to keep thinking of the Sustainable Development Goals, and where we're thinking about safely managed systems. What does that mean for sanitation, and the role that this can play in, I would say, in limiting the chances for future pandemics, and to increase the resilience and the response capacity in that sense. So thank you so much for this. Teixeira, would you mind sharing the very last conclusion slide that I have? Just the one before that, I believe. Yes, great. Yes, that one. Let's keep the conversation going. The second last, please. Thank you very much. So yeah, this is not a conversation that ends really here. There is a thread about this COVID webinars on the Sustainable Sanitation Alliance forum, Susana forum, and you're very welcome to find it and add your thoughts, questions, answers, and insight there. Also, feel free to contact us at slh@ids.ac.uk. We always read your emails and answer. Our website, sanitationlearninghub.org, is also a very good starting point to find helpful material about sanitation approaches. And this webinar is being recorded and will be uploaded on our YouTube channel in the coming days. Also, in the coming days, you will receive an email from us with all the links that you see here, and mostly also with opportunities to follow up on this conversation, for instance, through the Susana forum. This is to say that this is not the end of the conversation. This is really something that we are very keen on continuing with our speakers, panelists, and audience. So let me conclude just to thank everybody. Our speakers who have accepted to share their experiences with us, and the panelists who were happy to talk about it. And thanks to all the participants for their very thoughtful questions and the knowledge that they have been sharing by interacting with the speakers and panelists. And thanks also to UNICEF, who has supported this initiative. Our time is over for now. I will end this session, and you will be prompted to answer questions in a survey that will appear in your web browsers. So please do so. This is something that is very helpful to us. And drop us a line by email if you have more ideas for new webinars, new ways of continuing this conversation about sanitation, hygiene, and the new normal under COVID-19. Thank you so much. Thank you, everybody, and see you next time. Bye-bye.